Following that was in 1979, Geoffrey Hasler first performed angioplasty to treat AMI. So what made him different from Andreas Gunset was that he aimed to offer the procedure to as much as patients as possible, and he claimed that the only indication for bypass surgery is failed angioplasty. Remember, during that time, all cases of stenosis in the coronary arteries would lead to bypass. So here in Kansas City in 1980, he performed first the angioplasty in MI. Note the prior acute total occlusion in the LED, and followed by ballooning, noted the assumed patency of the artery. Following that, this was 1986. So the first stents were implanted in human coronary arteries in 1986 by Ulrich Sigwart and Jack Sprowell and his colleagues, and who placed a wall stent, sheeted, self-expanding metallic mesh scaffold in the peripheral and coronary arteries of 8 patients. Further experience with this device demonstrated high rates of thrombotic occlusion and late mortality, although patients without thrombosis had a 6-month angiographic restenosis rate of only 14%, suggesting for the first time that stenting could improve late patency in addition to stabilizing the acute results obtained after conventional balloon angioplasty. So the picture on the left is the Stent team. They celebrated after 100 implantations, and that was in 1988 with Christian Imbert Center, who is the engineer primarily involved in constructing the first stents, and Ulrich Sigwart, second from the right. So this first self-expanding stent used in humans seen in above, with the stent constrained on the catheter, while the lower view is half deployed by retracting the constraining membrane. The next year was 1991. So this guy, Gary Rubin, they developed contemporaneously with Cesare Gianturco, also known as the Gianturco-Rubin stent. It was a balloon expandable coil stent consisting of a wrapped stainless steel while resembling a clamshell. A phase 2 study evaluating the Gianturco-Rubin stent to reverse post-angioplasty acute artesian vessel closure was started in 1988, and ultimately leading to the United States FDA administration approval for the indication in 1993. Another contemporary stent was designed by Julio Palmas. It also a balloon expandable slotted tube, a stainless steel stent in which rectangular slots were cut into thin-walled stainless steel tubing and deformed into diamond-shaped windows during expansion by an underlying delivery balloon. This design allowed for relatively straightforward deployment. However, its rigidity made delivery in the coronary vasculature difficult. So in 1989, a design modification was made by Richard Schatz, consisting of placement of a 1 mm central articulating bridge connecting the 2 rigid 7 mm slotted segments, creating the 50 mm Palmas-Schatz stent, which was later produced by Johnson & Johnson. So the first coronary Palmas-Schatz stent was placed in a patient by Eduardo Sousa in Sao Paulo, Brazil in 1987. Following that is in the year 1989, which started the 2 landmark trials. So here, They enrolled two multi-center study, the stress and Stent, comparing balloon angioplasty alone to elective pulmonary shot stenting. In these studies, the use of pulmonary shot stent was associated with marked improved initial angiographic results and with a 20 to 30% reduction in clinical and angiographic restenosis compared with conventional balloon angioplasty. These results led to approval of the Palma shot stent by the FDA in 1994. And long-term follow-up up to 15 years subsequently demonstrated few late clinical or angiographic recurrences from years 1 to 5 after coronary stent implantation, with slight and progressive decrements in luminal size thereafter extending beyond 10 years. The mechanism of this late progression of disease are not entirely known, but have been hypothesized to be related to the development of new atherosclerosis within the adrenally stented segment rather than clot formation, as overall stent thrombosis rate have remained low at 1.5% at 15 years. So what we're discussing are the bare metal stents, but bare metal stents have certain limitations. So primarily, the limitation of bare metal stents as the default intervention at the time undergoing coronary revascularization was, of course, in-stent restenosis. While coronary stents increase acute luminal diameters to a great extent than balloon angioplasty, leading to a greater acute luminal gain, the vascular injury caused by stent implantation elicits an exaggerated degree of neo-intimal hyperplasia, resulting in greater decreases in luminal diameter, also known as late lumen loss, compared to balloon angioplasty alone. However, the incremental gain in luminal dimension with stenting compared with balloon angioplasty alone is typically greater than incremental increase in late loss, resulting in a larger net gain in minimal luminal dimension over the follow-up period. Okay. Okay, so this observation formulated the concept by Kant, which is bigger is better. And they demonstrated in association with better acute results following stent placement with a lower rate of subsequent restenosis. This findings was replicated independently of the stent device selected. So nonetheless, despite attempts to maximize acute gain through an upfront bigger is better stent optimization strategy, rates of clinical restenosis following BMS implantation approached 20 to 40% within 6 to 12 months, with even higher rates observed among the highest risk patients and lesion subsets. Such coronary restenosis became known as the Achilles heel of coronary stenting, with significant resources devoted to the study of its prevention and treatment. So following that, so in 1994, the FDA approved the use of stent to acute and threatened closure after failed balloon angioplasty. And then in 1999, Eduardo Souza again first delivered the first ever DES, which also is a third revolution. And following that, the approval of the CYPHER and Taxus stents. So here's the picture of Dr. Eduardo Souza. First deployed the CYPHER stent in Sao Paulo and Rotterdam. So what are the components of drug-eluting stents? So a DES that must be optimized to ensure its safety and efficacy are number one, the stent itself, including the delivery system, and number two, the pharmacologic agent being delivered, and number three, the drug carrier, which controls the drug dose and pharmacokinetic release rate. So for the first generation DES, which include the CYPHER above and which is a sirolimus eluting stent, and the Taxus stent, which is a paclitaxel eluting stent, which were the first two devices approved for clinical use in the US FDA. Both devices were based on existing BMS platforms coupled with non-biodegradable polymers. So this diagram shows the cell cycle showing the mechanism of action of sirolimus and its analogs, which primarily acts on the G1 or HG1, and paclitaxel primarily affecting the M phase. So in the two most clinically effective classes of agents are the rapamycin analog or the Limus family of drugs and paclitaxel. The principal mechanism of action of rapamycin, or also known as sirolimus, and its analogs. These analogs include zotorolimus, everolimus, biolimus A9, navolimus, and amphilimus. They inhibit the mammalian target of rapamycin, mTOR, which prevents cell cycle progression from G1 to S phase. So later in 2008, we showed the second generation DES. They are more refined. They have thinner struts. They are composed of cobalt chromium or platinum chromium alloys. And among them are the Endeavor, the Resolute, the Science, and the Promo series. So let's discuss the Endeavor. The Endeavor stent consists of a phosphorylcholine zotorolimus coating applied to a cobalt chromium metallic scaffold. Drug elution is relatively rapid with 100% of zotorolimus released within 30 days. It received FDA approval in 2008 based on the findings of the Endeavor series of clinical trials. Likewise, the Resolute DES also contains zotorolimus, but instead of the phosphorylcholine polymer, it has a tripolymer consisting of both hydrophobic and hydrophilic components, and approximately 60% of the drug is released within 30 days. Third is the Science Stent series containing everolimus and consists of a durable fluorinated polymer matrix on a cobalt chromium stent. Approximately 80% of the drug is released after 30 days. The Spirit series of trials evaluated the safety and efficacy of the Science system and was also FDA approved in 2008. And finally, the Promos family of everolimus eluting stents are also the identical fluorinated polymer as the Science devices. However, the stent platform is based on the Omega platinum chromium stent. The platinum trial established the Promos as non-inferior to Science in regarding to the primary endpoint of target vessel failure. For strut structure and design, so the struts, the rings, the cells, the crowns, and connector form the backbone of a stent. A strut is a single element that forms larger structural entities such as cells, rings, and crowns. The cell is a small but regularly repetitive structure of a stent delimited by two layers of rings and the connectors and might be open or closed. And the connectors attach the adjacent rings and can be straight or curved. Sorry. Yes, thank you, doctor. Can be straight or curved, or can be direct welds that link the rings directly. So the rings and crowns here. So one crown is equal to two struts. It is a compromise of a cluster of cells and are held together by connectors. So the orientation of the stent in phase or out phase and connectors can be offset peak to peak, mid shaft, peak to peak, out of phase, or peak to valley in phase. So the design and geometry of these components define the mechanical performance of a stent. Crowns and rings determine the radial support and expansion capacity, and the number of connectors is responsible for the longitudinal stability, flexibility, and deliverability, side branch access, and longitudinal integrity. Open cell designs with a reduced number of connectors provide greater stent flexibility with reduced arterial injury and decreased near-intimal response. For coil designs had greater strut width, but gap and fewer or no connection between the struts. The strut width is greater and there are gaps between the struts and no connection between the struts give it more flexibility. However, the design lacks radial strength and the wide gap allows the tissues to dangle. As a result, coil design has become obsolete and replaced by the more superior in radial strength, the tube design. In tubular, there are two types of specification, a slotted tube and a modular tube. Slotted tubes stents resisted restenosis more than the modular stents by 22% versus 25%. A slotted tube or closed cell design can be either open or closed. So here is an example of closed cell design and open cell design. So depending on the cellular configuration, multicellular stents can be broadly subclassified as either open or closed. So for the open, again, not all struts are interconnected with an open area of around more than 5 millimeters. Their designs tend to have a varying cell size and shapes along the stent and provide increased flexibility and delivery. Again, the closed cell design, however, usually are interconnected stent struts with an open area of less than 5 millimeters. So they incorporate and repeating unicellular element that provides more uniform wall cover and each with less tendency for prolapse at the expense of reduced flexibility and side branch access. So this is a close look of drug field design. This is from Medtronic. Note the sinusoidal strut design with laser drilled elution ports on the exterior aspect of the stent and providing access to the drug field core. So this is a comparison of the first generation and second generation stent. But the colored image around is the drug and the layer underneath is the drug polymer and the black image is the stent. So ideally what we aim for a perfect stent is that which have a deliverable and retrievable. It doesn't fracture, deform, cannot produce thrombosis or restenosis. Have a good delivery system profile and have great radial and axial strength, decreased platelet connectivity and good healing, and drug coating and lead healing also. So following the second generation stent are the third generation stent. So these are biodegradable polymers. While polymers are crucial in effective drug delivery, their persistence may also elicit inflammatory response, leading to late and very late stent thrombosis, even as well as stenosis. So there has been great interest in DES with biodegradable polymers, even novel polymer-free DES. So as a good example is the Synergy Everolimus Eluting Stent, which is based on the platinum chromium platform. However, the polymer coating is composed of biodegradable polydilactide coglycolide or PDLGA. So the PDLGA polymer is fully absorbed after 3 to 4 months, eliminating long-term polymer exposure. It was approved in the US in 2015 based on the pivotal trial of Evolve 2 study, which showed that the synergy stent to be non-inferior to the PROMOS element plus in regard to target lesion failure at 12 months. Following that is the approval of the bioabsorbed BVS or the bioabsorbable vascular scaffold in Europe in 2011. So what are bioabsorbable drug-eluting stents? So despite the improved efficacy with DES, late stent thrombosis and target lesion revascularization still remain major concerns. The continued presence of metallic struts can promote instant neoarteriosclerosis, recurrent stent thrombosis, and restenosis. Thus, the idea of bioresorbable scaffolds has gained much interest, given that they could offer potential advantages in restoring natural vascular instruction and function. The resorption of the stent could make future revascularization easier if needed, especially in cases with side branches. However, in September 1998, the first bioresorbable stent by Ikagi Tamai showed that at 5 years, the iterative revascularization was higher at 18 compared to 5.3 in CYPHER. Remember, CYPHER is the first generation DES. And this another study was done by Absorb, which is an everolimus eluting polylactic acid-based bioresorbable scaffold or BBS, and was first completely bioresorbable DES brought into clinical use. It was FDA approved in 2016 but was later commercially withdrawn when follow-up data showed more harm with BBS, such as here. At 5 years, the MACE was high at 3.4 compared to the DES. And even after the first absorbed study, they produced another absorbed study, absorbed 2, which is a trial randomly assigned 501 patients in a 2:1 ratio to receive either the adult absorbed BVS or the science DES. So they noted here at 3 years follow-up, the absorbed BVS did not meet the primary outcome of the restoration of vasomotor activity or late luminal loss. And likewise, they still followed up with an absorbed study, which a larger sample size and with 3-year clinical outcomes, and reported higher rates of target vessel MI, 8.6 versus 5.9, and device thrombosis at 2.3 versus 0.07, compared with the cobalt chromium everolimus resistance. So currently here are the current approved stents in the United States, which are commonly also found here in the country, the Science, the PROMOS, and the Resolute stents, so as Synergy. So in summary, significant progress has been made with second generation DES compared to their first generation counterparts in terms of enhanced deliverability to thin-strutted cobalt alloy or cobalt chromium or platinum chromium platforms, and safety, including the ZES, EES, and BS, and the anti-restenotic efficacy. The development of new generation DES and novel bioabsorbable scaffolds will no doubt continue, but finding incremental improvements and instant performance may be challenging. So currently, stents are mostly produced by laser cutting or other fabrication techniques like electro-discharge machining, water jet cutting, photochemical etching from tubing, and various wire forming techniques such as braiding and knitting. However, these technologies can be updated or replaced through advancement in augmented reality, 3D printing, and deep learning. And specifically by making use of the information gathered about blood vessels to the AR and DL, augmented reality and deep learning, materials like the polydioxide and metallic glasses can be 3D printed into cardiovascular devices with more distinct design than commercially available ones. So one of the major findings from the failure of the BRs or the bioreabsorbable stents uh, was that the strut size was too large and induced turbulent flow, which resulted in the activation of platelets causing coagulation. Here, such as the ultra stent, approximately 100 microns. Shots had been explored for all stents, but also in helping improving the BRS. So the first figure is a schematic diagram of stent shot causing disruption due to the large stent shots. It disrupts the laminar blood flow, resulting in platelet aggregation and reduction of the vasomotive signaling molecules. On the right is the histological process of the stent, surrounded by atherosclerotic platelet region. And the blood flow here was from left to right. While on figure C is the ultra-thin stent strut promoting laminar flow, keeping an intact endothelial barrier and allowing vasodilation promoters to act. So inhibiting the coagulation cascade activation. So as shown in the histologic cross-section of an ultra-thin stent strut with minimal platelet aggregation surrounding the strut. So early diagnosis of in-stent restenosis is currently almost impossible to detect, and it relies on the patient having significant chest pain or worse, a second cardiac event. So those patients fortunate to have their ISR detected still rely on lifelong medication that may require subsequent PCI with additional DES deployment or drug-eluting balloons. So a solution are stents with integrated sensors that can detect growth of cells, the different cell types, and those that can measure changes in flow and pressure across the lesion site. And a way of achieving this within a limited space is through a stent microelectromechanical systems or a MEMS technology. These devices will rely on Kussmaul and Bernoulli equations, detecting differences of pressure and flow at two given points across the stent. So these are the example of the different sensor designs. One is the schematic of a stent and pressure sensor in a vessel with instant restenosis. And figure B is a cross-sectional schematic visualization of a biodegradable capacitance and resonator sensor. And C shows example of a diaphragmatic pressure sensor with deflection of a silicone membrane when pressure is applied. And finally, D is a magnetoelastic response resonator incorporated within a stent scaffold. Primarily, these are still in development and several designs are still upcoming with possible future outcome. I think this is my last slide. Thank you.
So thank you, Lester, for this insightful and in-depth discussion of the stent morphologies. Are there any questions from our participants?
Thank you for your time for attending.
So I think this is important. This is the main difference of the stent companies, mainly their stent morphologies. This is one of their selling points, giving them additional benefits or comparing them to others. No? So of course, thinner struts could be better, but not too thin that they fracture. And then some stent designs are more easy to handle, for example, bifurcation stenting as compared to those closed cell designs. So I think there are no questions. There are no other questions.
We'll just have a short presentation from our sponsor after, Doctor.
Okay. I'd like to thank our consultants for attending our conference today.